We're just going to wait 30 seconds for the broadcast of this meeting before we'll get going. So if you'll bear with me for 30 seconds while we wait for IT. Thank you. Right. Good afternoon to you all. Very warm welcome to this Western Cape Provincial Parliament Ad Hoc Committee on COVID-19. I'd like to welcome all of the members. It's been about 3 weeks since we'd last seen each other. I hope you all had a constructive constituency period and have returned in good health. We'd also like to welcome the head of the Western Cape Provincial Health Department, Dr. Fertility, and his team, as well as the officials from the Department of Health. We'd also like to welcome members of the media and members of the public joining us in our meeting and tuning in on YouTube. I have received an apology from the MEC of Health, Dr. Nama French-Mbombo. She is conducting oversight at a COVID hotspot outside of the metro presently and was not able to join us. I have not received any apologies from the members. Are there any apologies that members or officials would like to table at this stage?
Chair?
Yes, Honourable Syed.
I'd like to table an apology on behalf of Member Vint Vogel. As you know, she's also like the Premier. She was also affected by COVID-19. So, yeah, she's also resting at the moment.
Thank you. We wish her a speedy recovery.
Thanks.
Are there any other apologies? None? All right. Before we get going with the meeting, I'm just going to remind all about the rules of engagement for our virtual meetings. All members are muted at the start of this meeting to avoid background noise. Members should please flag points of order using the raise hand function or using the chat function. Please keep the chat function free of chit-chat and it's to be used for technical or points of order only. I ask that all audio and video be switched off to improve the quality of the connection. However, if a member, the minister, HOD or official is speaking, please do put on your mic and your video. We ask that participants turn off their mics and videos once they have finished speaking. We ask that presenters unshare presentations once the briefing has concluded. So with that out the way, today we will be receiving an update by the Western Cape Department of Health on the situational analysis of COVID-19 pandemic in our province, including what the health indicators look like, what is the health response to the pandemic at the moment, what our death rates look like, what are our peak projections, what's happening with testing data, what are our future projections, and what will the new normal in the health system look like post the peak. So a lot has happened in the last 3 weeks, and we'd like to thank the Health Department for being with us today and for briefing us and the residents of the Western Cape on the progress of the pandemic. So without further ado, a very warm welcome to you, Dr. Fertility, and your team. I'm not sure if you'd like to make some introductory remarks and introduce your team before you get going with the presentation. Good afternoon.
Good afternoon, Chairperson. It really is an honour for us to come to the ad hoc committee to account for what's happening in the Western Cape. I do so proudly as the head of the department in the Western Cape. I would like to just introduce the members that have joined me. Dr. Beth Engelbrecht is the previous head of department. She's taken up a position, a contact position in my department, in my office as a strategic manager to support me for the 6 months of the first initial introduction of my term. Dr. Krish Vallabji is the head of strategy. He has joined us. He's done most of the preparation in terms of the slides, the data, all the intelligence that's gathered works in his area. And then Dr. Sadiq Karim is the head of operations, is the chief of operations, the previous position I held in the department, and he's been promoted into that position. So this is our senior management team. We humbly in front of you to account for what we're doing. Thank you. You are muted, Chairperson.
Thank you. I was having a soliloquy there. Thank you very much. Please feel welcome. And at the outset, we'd like to thank you and your team for the very hard work that's been put into managing this pandemic. We know it's been very difficult. So on that note, be welcome. And are you able to kick off with the presentation? We'll then have a Q&A session once the presentation is concluded. Thank you.
I'll be guided by you, Chairperson. I know the last time our presentation was a bit long. Again, the slides that we gave you is numerous. I'm guided by you. If you tell me exactly what the presenting time should be, I will then be guided, and I will not spend or dwell on every slide to give you a broad overview, and I will cut the presentation in accordance with what is the expectation of the committee.
Thank you. You're the only department presenting today, so we have the full 3 hours. So if the presentation could be approximately 1 hour, that gives us 2 hours for a Q&A session, which I believe will be adequate. Thank you.
Thank you very much, Chairperson.
Okay.
Okay. So let me just bring up the presentation. I assume that everybody can see that, Chairperson?
Yes, we can.
Yeah. So I'd just like to thank you very much for the opportunity. And again, because of the time frames, I just want to make a statement right up front that we submitted these to you last Friday. So therefore, the data that we have is the latest data updated till Thursday last week. So obviously, you can understand in COVID, things move quickly. And wherever relevant, I will speak of updates since then. But all the slides are prepared as if it was last week. So what we're going to quickly do is just step in with you and just tell us what the health data or the indicators currently say. What are the future projections in terms of death rates and peak projections? A little bit about the containment strategy. Quite a lot of members from the ad hoc committee has asked many questions in relation to the containment strategy. I will touch briefly on that. And if need be, we can probe a little bit more if that will come out, I guess, in the questions. Then just a testing strategy update, our health platform response, and then the issue about hotspot strategy and I would say the behavior change that's required, and then the new normal and what the health system possibly would look like post-peak, and what we're working on currently as a team. So just to start with the data update, one of the important things that we've realized in this, and I'll come towards the end of the presentation, is the importance of data. So what you see here is Thursday, the 9th of July, and it says 2:27 p.m. This is a data summary that we produce every day at after 1 o'clock. So 2 o'clock, 1 o'clock, 2 o'clock every day. So you would have seen since Thursday the 9th, we would have had a data summary. And the data summary for today is probably going to be released in the next half hour. But it's a daily summary. And what we do in the daily summary, it gives us the cumulative test. So up until Thursday, 340,000 tests were done in this province. It gives us the cumulative cases up until then, 74,000 then, of which 16,400 were active and 55,000 recovered. And the total deaths on that day, 2,224 on that day. What we've now started introducing is is to give a sense of what that picture was like 4 days before then. So it also gives you a running total of the last 4 days. So if there is 74,000 cases on that Thursday, 4 days before there were 1,700 new cases. 3 days before there were 1,200 new cases. 2 days before there was 1,030. The day before, 1,800. And that day that we reported, there was 700, so just short of 800 tests that day. Similarly with the deaths, we're now giving you a running total that 4 days before there were 40, 3 days before 35, 44, the day before 50, and on the day 30. And then also the admissions in hospitals. We give you all the The current admissions in the ICUs or high care, this is public and private, 260. And then for all COVID-related cases, 1,400. And what we call persons under investigation, 6,900. So at that day, 2,400 people were in hospitals in public and private. If you take the persons under investigations out, so for COVID patients, it was 1,700, but 700 were people that were under investigation for COVID. That doesn't mean they have COVID. We're waiting test results to see whether they got COVID. And then also still the question on community screening. We are still continuing doing community screening. There's 885 to date, 885,000 to date, of which 16,000 was sent. And you can then see the number of deaths as then gone up. And the point that we're making here is this is the daily number of deaths. You can see that we peak somewhere at about 50, 56, but in the last week or so, our daily number of deaths has started stabilizing and it's starting to even possibly show an early decline. Then what we also do daily then is then give you that same figure that I've just shown you now, is then a breakdown per district. And this is the city of Cape Town. It gives you then the picture for each sub-district. What are the total cases? What are the recovered cases? What are the active cases? What are the recent cases? The cases in the last 7 days compared to the previous 7 days? And what is the difference between the two? So there you can see the difference between the two. Then also per 100,000 population, what is the active cases per 100,000 population, or the total cases? And then in the last 7 days, admissions in hospitals, the same, and then deaths in deaths as well. And then healthcare workers, the total number of people infected as healthcare workers also broken down. There will be an adjustment to this report, which I will explain a little bit later after I've given you the forecast going forward. And then this is just briefly Wynlands, Overberg, West Coast. Similarly, and you can see, as you can see in the metro, there were less cases in the last 7 days compared to the previous 7 days. Whereas in places like Overberg, where the epidemic is slightly later than in the metro, there's more cases in the last 7 days with the comparative 7 days before. The same with West Coast. But Cape Wynlands is starting to look like the metro, where the last 7 days had less cases than the previous 7 days. So there's also a pattern in Cape Wynlands that are starting to move towards what we would call stabilization. Same with Garden Route, still on the increase in the last 7 days. And then Central Karoo, for a long time, had very few cases. And then Central Karoo would obviously started showing cases in Beaufort West itself, in Laingsburg, and in Prince Albert, and then started showing increase much later than all the other places. What we also do is a very detailed investigation, and we also have a daily report like this that tells you every day how many people have died, and we break it down in the age groups 20 to 29, 30 to 39, all the way up above 70. And we break it down into who had diabetes, hypertension, cardiovascular disease, chronic kidney disease, lung disease, obesity, cancer, HIV, TB, and other comorbidities. And then whether somebody had 3 or more comorbidities. So again, it's a tracking of what we've done. And then we also track children under the age of 19. And there were only 8 deaths under the age of 20 by the 29th of June. And each of the children are each of the deaths are being investigated, but every single one of those deaths has a significant comorbidity or predisposing condition associated with it. So that's the COVID in less than 20 years. It's only 6% of all cases. And then if you look at the age groups of under 20, you'll see it's a reasonable split amongst all of them. But generally, the cases are much milder than in the adult cases. And I said only 8 deaths, and the 8 deaths are with really very clear pre-existing conditions associated. There was a specific pattern that we investigated, and that was to look at the mortality specifically in Khayelitsha and Klipfontein. And we did a preliminary review. And that was to see in those many sub-districts, obviously in the metro, there was established transmission. And Khayelitsha and Klipfontein has the highest number of deaths due to COVID. So we analyzed it. And this is the analysis. So This is the number of deaths. So we showed it there as Klipfontein and Khayelitsha, followed by Tygerberg, Southern, etc. Then when we analyzed it, the deaths per million, you would then see in Khayelitsha it was just under 600 per million, and Klipfontein was above 700 per million, compared to just over 300 per million in the metro and 250 per million in the Western Cape at that time. I must just stress that these numbers have also shifted since then. Case fatality rate, this is just to say out of the total cases in those areas, what percentage. So in Khayelitsha, at that time, of all cases, just less than 4% were dead. In Klipfontein was just, of all cases, less than 5%. Cape Metro was just over 3%, and Western Cape just under 3%. And this is what we then started seeing, because we then started seeing that actually there was a peak of cases just at about 50 cases in that area, Khayelitsha and Klipfontein, and then a decrease started decreasing, and that trend has continued. This is the overall case numbers in the metro, and you can also start seeing a peaking, and we would want to then come back to this to explain that to you afterwards. But if we look at in Klipfontein specifically, and this is where the suburb data then needs to come in, so we analyze it and see that more than half of the cases, if you look at Klipfontein, was in Gugulethu and in Nyanga. So Gugulethu and Nyanga accounted for more than 50% of the cases of deaths in that area. So it is 114 in Gugulethu, Nyanga 157. Again, I'm stressing it's the numbers at that specific time. The numbers have shifted since then. If you look at Khayelitsha, unfortunately, the suburb data is non-specific. So there's a lot of suburb data issues which is just mentioned Khayelitsha and just mentioned blank. And this is in the cases of positive tests. So this is the only data we can get on the lab result form when it comes back. So the address data is a challenge when people capture it in terms of that. So it seems to be very evenly spread through all of that, but it's this big number of cases where the addresses were indeterminate. But if we look at the comorbidity profile, so this is just to take you back to what I just said about number of people having these different diseases. In the Western Cape, hypertension, and this is now, if I explain this to everybody here, this is the morbidity. This is the morbidity profile, comorbidity profile for everybody that has COVID. So if everybody that has COVID in the province, the most frequent comorbidity is hypertension in everybody that has COVID. But you see also the majority of the people that has hypertension with COVID actually recover. So it's 5,229 that recovers. 925 dies. And then there are people that were admitted to hospital, and then there are people that are still active. If you come to diabetes, it's the second most common, but proportionately more people die of diabetes. And I'll come back to that factor, that it's 876. So out of all the people that have diabetes, the proportion that dies from diabetes, as opposed to the proportion that dies from hypertension, is bigger in diabetes. And so you can go with HIV, with TB, with asthma, chronic kidney disease, others. When you come to Khayelitsha, the analysis of comorbidity of all cases is that the biggest, most frequent comorbidity for people with COVID in Khayelitsha is HIV, but it's not the highest number of deaths. So if you look at it, it is the number of people have HIV that has HIV as a comorbidity. Obviously, the most recover, and some proportion of them also die. But again, the biggest number that dies in Khayelitsha is actually because of diabetes, which is 140. Although fewer people that has COVID has diabetes, more people die because of diabetes. And that you will see that trend start carrying through into the rest of the analysis we do. If you go to Klipfontein, again, it's a very similar picture to the provincial picture, is that hypertension, again, is the most common amongst COVID positive people, followed by diabetes. But again, the proportion of people dying of diabetes is higher, followed by HIV, followed by TB, followed by asthma, followed by chronic diseases. So in a sense, what we've then realized is that the age profile for people with COVID in Khayelitsha is a younger age profile, whereas the age profile for people dying, for people with COVID in Klipfontein is an older age profile. So that's the difference between the two, and therefore the factors in Klipfontein is more linked to age and diabetes, and well, for COVID, and in Khayelitsha is younger, and it's HIV and younger and fewer hypertension and fewer diabetes, and that's the profiles difference that we see between the two. So the conclusion of that preliminary review is that the districts have had the highest number of deaths per sub-district, and it's aligned also that they were amongst the highest number of cases. But over and above this, the rate of death in relation to the population is high in both compared to the city and the provincial average. In Klipfontein, the suburb distribution, as I said, is Gugulethu and Nyanga. In Khayelitsha, the address data is incomplete, but it's obvious concentration of death. There's no obvious concentration of death in particular suburbs. The number of deaths appear to be stabilizing. It's too early, and we will come back to that. And the above analysis suggests that Khayelitsha and certain suburbs in Klipfontein are particularly vulnerable with respect to mortality and should receive enhanced attention. So I'll come back to that issue. About specifically, this may be part to an increased comorbidity of HIV and TB in addition to chronic disease of lifestyle, and we need to look at it further. But really what we've recognized from there is to go in earlier into those sub-districts and find people that has comorbidities earlier and enhance our alertness to prevent mortality in those two sub-districts. Furthermore, socioeconomic conditions also contribute to the risk of disease and subsequent mortality. So it is a factor that we know where the socioeconomic conditions is of greater challenge, as a bigger challenge. The predisposition for the comorbid conditions is higher. Therefore, the risk of mortality for COVID is higher. If I go to the next set of slides, the next big one is the impact of alcohol on trauma load and health services. So what we do in this province, which is something that we have as a very useful system, we call it the Sentinel Trauma Report. George Regional Hospital, Mitchells Plain Hospital, Grootske Hospital, Heideveld, and the Tygerberg Hospital, the medical emergency in Tygerberg. In those 5 places, we have this system called Hectors. It's an electronic system for emergency centers, and we can really pinpoint per case what happened. So it's a very detailed database. That data showed us 2 months pre-lockdown and the alcohol ban, we were running at that level. 2 months during the lockdown and alcohol ban, there was a significant reduction of trauma cases in those 5 hospitals. 1 month after the lift of the alcohol ban, it shot up again. So this data is very sensitive to tell us that that was the picture. And there was a 40 to 50% reduction during lockdown and alcohol ban. And when it's lifted, that almost returned back to the baseline before. The more worrying thing for us was, though, that the daily average of trauma cases requiring ICU or high care pre and post lifting of the alcohol ban. So between that week, the 22nd to the 31st of May, there was 2.7 beds used per day due to trauma in the ICU or high care. A week later, with the alcohol ban lift, that jumped from just short of 3 beds to almost 10 beds being used. Now, can you imagine? It's 7 additional beds that's been taken out of circulation that could have been available for somebody with COVID. So that is a very significant impact on ICU and high care capacity linked to trauma. And then the impact on deaths from the road traffic accidents. Again, in May, on average, there was 1.44 road traffic accidents. In June, after the ban lift, that shifted to almost 4 road traffic accidents per day. So again, a significant increase based on and from us linked to the lifting of the alcohol ban. And how do we say that? We did a detailed study of 6,770 injury deaths in 2016, and we tracked them. 51% was homicide, 11 suicide, transport-related other accidents. And in that, we went to check the alcohol levels. 50% of homicide victims tested positive for alcohol. 60% of pedestrian fatalities, alcohol. 47 motor vehicle accidents, alcohol. 65% fire fatalities, alcohol. 47% of drownings was related to alcohol. So the link between trauma and alcohol is an established phenomenon in the Western Cape, especially on the Cape Flats, and predominantly affecting males as opposed to females. So the summary conclusion of the impact of alcohol. So as we approach the peak for the epidemic, emergency centres are being inundated with severely ill COVID patients, emergency management and admission. The lifting of alcohol has effectively resulted in increase in the daily trauma cases in ECs, 40% cases requiring admission, trauma admissions increase, and trauma deaths increase in the EC. It's depleting our ability to be able to manage both of these as we remain at the peak. And we have noted that from our perspective, alcohol ban would be beneficial for the health services because it takes the burden away from the healthcare service that is needed for COVID. Then the scenario projections. So I need to stand a little bit with this, and just to explain to the committee that the last time we were here, we presented a scenario which is the purple scenario. So I'll take my time just to quickly explain the difference between the purple scenario and the turquoise scenario. So the purple scenario at the time, it was what we call the National COVID Epi Model. I did quite a lot of preparation last time to present to this committee what that means. So that is the modeling group of which Masha at UCT is part of, and they're working with other entities. And that's the national department's modeling that they do for all COVID across all 9 provinces. Now that, when we came to you the last time, we predicted quite a steep, or that model predicted quite a steep and a high peak towards the end of July. So that is what that the purple was. It also predicted with that steep incline. So on the left-hand side is the number of cumulative deaths. So this is how many people are dying, and we add every week to the total of cumulative deaths. So according to that, we would have had cumulative deaths just short at the end of about December, just short of about 10,000 deaths in this province, according to the model. According to this model, we needed 5,800 beds at that peak at the end of July for the peak of how many people will need in that last week in July a hospital bed. What has happened is because they tracked, and I explained the last time that our figures were slightly lower than what the model predicted. The modelers then recalibrated their model, and that was about 3-4 weeks ago, to the turquoise scenario. So they then said, okay, it's going to be flatter, and it's going to take a little bit longer. But if you take on deaths, they still said we're going to even have slightly more deaths because this is now a flatter, longer curve. So they predicted it will be flatter, it will be later, which takes us to the end of July, and it will be longer. So if you take that area under that, they then work it back to say, therefore, you are actually going to have not so much a high peak in deaths, but more a longer trajectory of COVID. Therefore, they predicted even more deaths towards about 12,000 by December. So I just want to give you the context that we're now working on the turquoise scenario, the revised national COVID epi model, and against that one, we are now tracking. So what I'm showing you now is even with this new, the black is the previous one. The green is now the new one. And the Actuarial Society of South Africa also added the yellow line. So they similarly made these assumptions. So what is happening now? We are now, this is still a risk scenario for us. We regard it as a risk scenario. Because what happened is our real data is what's happening on the dotted line. You start seeing that actually we're starting to flatten here as opposed to going up. That was the risk scenario put by them, and they were still making assumptions that there's going to be quite a lot of continued infections. Our early data is now starting to say to us. So then the question was, actually, are we potentially not picking up all the deaths? And the question is, should we be looking at what is happening with home affairs? So what we then do is we then track our deaths against home affairs just to make sure that we are not missing deaths in terms of that. So when we go to home affairs, and currently The vital registration is done by the Medical Research Council together with UCT. They get the Home Affairs data. And I can say to you now, to the committee chairperson, is that we've now, this is last Thursday, but since then we've got more additional data. And what you see here, which is roughly a peak to about the 17th of June, we now have data till the beginning of July. And the subsequent weeks have actually started coming down. It's there, and there. So we've now got 2 weeks of MRC data tracking against the Home Affairs data for the whole country. And I just saw the weekly update that they've done for the week of the 7th of July was sent this morning about 3 hours ago. And again, Chairperson, I can forward that to the Secretariat and then show everybody. But that has shown a decrease that's there now. And now it shows the comparison of deaths in every metro in every province in the country. So it actually starts showing the Gauteng deaths, the comparison that we can see between this, the Gauteng deaths, what's happening in Eastern Cape and everywhere. So that is what we then track. And we again are now very confident that we are actually picking up most of the deaths that we are reporting. It's very much in line with what the MRC is picking up. If I come to hospitalizations, so just to explain to you, the yellow line here is ICU public sector beds. That's mainly Grootske and Tygerberg for us. The red is ICU private sector beds. Now, it's a bit small, but you will see both the yellow and the red has tailed off and starting to stabilize. The light green is the public sector general beds. And you can see towards the end there, it's starting to peak a little bit and coming down. And again, we've now an additional week of data. It shows that trend continue a little bit further. The olive green is the private sector general beds, which also comes down. And the gray, if you can remember what I said about persons under investigation on the first slide, that's the number of people, the 700 people that are not COVID, but they're being investigated. They could have flu. They're being investigated to see whether they have COVID. If you take all of that together, against the scenario, we are starting to flatten and move in that direction rather than following, let's call it, the scenario that's currently on the table. And then what we then do is, just to go back, is to then look at all of this. Again, this is the Khayelitsha Mitchell Spain. You can then see that's the one that we checked earlier. And we can show you now, Khayelitsha Mitchell Spain is coming down. Sorry, Khayelitsha Klipfontein, that's the two we looked. This one is the total metro. And as you can expect, the rural is still slightly going up because in the rural, the deaths are still behind the metro. And there's still a bit of an increase in terms of this. So it's early days, but it's really looking like both the hospitalizations and the deaths are stabilizing and even potentially showing an early decline in the Western Cape. What they've also now done, the NCEM, with the rider, that we understand now that this peak is actually, it's flatter. What we really see is flatter. But anyway, they've given us district models. So now we can say for West Coast, for Cape Winelands, for all of these ones, and they're all there. It's a slightly later. So we can see now, Metro was earlier, Cape Winelands slightly later, then West Coast, etc., etc. So now we can also do differential planning possibly for us saying that actually Cape Winelands will be slightly after the Metro, but West Coast and Overberg will be slightly after that. And you can understand now that Garden Route and Central Karoo will even be slightly after that. And we can then titrate and nuance what will happen across the province. So the general comments is this recalibration until the 19th of July. So we've recalibrated the Western Cape data until 19th July for mortality and admissions. There's a broader, flatter trajectory with more deaths and hospitalization, but over a longer time, lower peak service need. We consider these as risk scenario. As I just said to you, it's a risk scenario to plan for the worst case scenario, but possibly based on the trajectory to date. And so possibly based on the scenarios that we need to be prepared for. But extensive uncertainty remains, including the example of dexamethasone and a few other things. But we are now early days seeing that we are starting to flatten and we need to monitor it. But early days, it's starting to flatten because both the deaths and the admissions are starting to flatten and possibly even starting to decrease. Then I go on to the containment strategy. just to make this point very clear, that the Cape Metro screening still continues. Rural screening still continues. In every sub-district, we do screening. But what's currently happening in the Cape Metro? The community health workers, in groups of 10 to 15, they are expected to do 5 household visits per day. So they screen all the occupants of the households for COVID-related symptoms. They also perform non-COVID activities. So they're also looking at the home delivery of chronic medication. They check whether there's a TB, HIV patient there. Is there children that's not been immunized? So as the community health workers go into this phase of work, they are very much looking at COVID and non-COVID at the same time. But they're also supervised by a professional nurse and an enrolled nurse. And each group is allocated to a specific area to focus on. So you can take a place like Khayelitsha and break it into 10 different units, and there's community health workers that goes into each one, and that is what they do in Khayelitsha. The same with Klipfontein, the same with Garden Route, the same with Beaufort West, everywhere in the province. But what we do now is we look at symptomatic patients at high risk of COVID morbidity mortality. So I showed you all the comorbidities. And we then say, but if somebody is over the age of 55, if they have diabetes, they have hypertension, they are more likely to be iller, to land up in hospital, and potentially more likely to die from COVID. So we focus our energies on finding them and then say, do we need to make sure that they get referred into the primary care facility quicker? And also our testing criteria supports that high-risk strategy. Other symptomatic people get health messaging, and they get checked for self-isolation. But all clients are currently offered the assisted quarantine and isolation at the designated facilities. So we are now actively promoting in every household visit, in every primary care visit, and I'll come back to the training, to the call centers and the contact tracing. Everybody's doing that. CMOR is a system that is loaded on a cell phone. It's an app. And what the community health workers then do is they track everybody that they screen on that app. And we can then on a snapshot just electronically capture all the screenings, which is now the reason why we can constantly every day update our screenings. The next big thing is that there are teams at every sub-district that currently contact each index patient who have tested positive and do contact tracing, symptom monitoring, and also offer the quarantine and isolation. There has been a backlog, and that is slowly being addressed. So that contact tracing team has not necessarily over the last 4 weeks been able to get to everyone, but they have systematically worked through it. And I'll come back to that because at the peak, when the cases were the most, it was also when there was a delay in the testing that it became very difficult to keep track of everybody. In addition to that, there is now something called track and trace. Now, track and trace is not a GIS tracking of somebody on their phone. It is a software system that each of the clients that comes for the test are encouraged to put the system on their phone. So it's an app. And once you take your test and you give your details and you load the app, the laboratory will send you an SMS notification the moment your result is available. But they also get SMS notifications for basically just supportive messaging. It also gives you an option on your app that you can self-enter. Think of all the people that you were in contact with. So you can actually enter, I was in contact with this one, that one, that one, that one, if I'm positive. And then through the app, you can also now start doing contact tracing. And you can do symptom monitoring because there's a slide that says, tick every day. How do you feel? Do you have a cough? Don't you have a cough? And we can track from the track and trace your symptom monitoring as well. This was a pilot started on the 8th of June in the Metro. It has now been so successful in the Cape Metro that the minister launched it last week as a rollout for across the country. And I think the president made an announcement on Sunday in relation to this as well. So ideally, the clients that do not engage the Telkom track and trace will then be contacted by call center agents. Now, we also have a call center that now also check and phone and offer quarantine and isolation. And in addition to that, we have what we call pods. These are specifically more skilled health professionals, and they phone the vulnerable people to check their symptoms, the diabetes, the hypertension, and really check whether somebody really needs to come in quickly for medical attention, to pick them up early and manage them effectively quickly. In the rural districts, they have the equivalent of pods and teams at sub-district level, and the track and trace is now being rolled out to them as well. So that is our full ambit of tracking and tracing people, and it exists in every sub-district. They have data, they track it, and that's what we do in our system. This is just to give you some indication. This is the COVID negative result. So it doesn't mean that you on track and trace that you will get a positive result. It's a COVID negative result. And it tells you here that of the people with the cell phones, 93% have received their results to say you are negative. Then you can see percentage engaged. So they click on the links and they stay engaged with it. 14% stays engaged with this. The positive results, 91% have got their results, and people that's positive actually is a little bit more engaged because there's more incentive to be engaged. So up to about 20% of people constantly go in, they track, they check their symptoms and all of that. And then obviously this is now a good sign for us because we can now start working via this app, and there's lots of information in the app of everybody that is enrolled on this app. The call center takes up, is scaled up to take over 100 call center agents, and they handle about 1,000 cases, contacts per day. So this has been a big addition in the last couple of weeks. They call cases and they call contacts. So they call the case, and they also then call the contact of the case. They identify a client who needs isolation quarantine, and each case is repeatedly offered quarantine during each call. So this is the stats from the 13th of June to the 6th of July. 4% has been referred to medical officer and hospitalization. So this is the call center calling somebody, and the person sounds like they've got quite severe symptoms. They're elderly, they might be in need of medical care or even hospitalization. They get referred to a medical officer immediately. 267 people in that period were referred for that. 915 actually took up what is called Western Cape Government Accommodation. This is the isolation and quarantine designated facilities. So 14% of people actually took up from the call center that. Now you can see that the bulk though is people, even after the default of saying, please go to the designated facility, people prefer to self-isolate. 36% prefer to self-isolate. Quite interesting from the call center, 149 people were actually healthcare workers, because that's the positive results we get. That's 2.3%. 350 are deceased, so that is the deaths that occurred. So the positive test comes out, and the call center try and call the person, and then find that the person has died. So that is, positive results come after the person has died. And that's part of our death report. A big concern for the call center is that 2,100 cases goes unanswered. So either the person refuses to pick up their phone, or they give a wrong cell phone number. And that is one of the things that we're trying to work back into this, that we really want to, at the outset of where somebody takes the test, and we have a very good example in Mitchell's Plain where they do it very well, where the person that takes it in Mitchell's Plain takes it very well, and that you get the right cell phone number at the time that you do the test, so that your follow-up rate can be improved. But this is a concern for us, that people are not answering their phones. Then quarantine and isolation. All clients with symptoms that needs to be hospitalized, they are hospitalized. All symptomatic clients not requiring hospitalization, they are currently giving assisted quarantine with or without testing. And all that are tested are offered isolation. So again, the uptake rate might not be that big, but it is offered. These are the reasons people give. Can I smoke? Can I drink alcohol? Can I leave to visit my family? What about having sex? Everyone will know I've got COVID. Who will look after my house? Can I come and go as I please? So there's a lot of reasons. And out of all of this, with all the motivation and the intention, up to about 80% of people decline the offer of isolation and quarantine. That's despite all our energies to do that. This is the uptake. I apologize, Chairperson, it's a little bit small, but it just shows you that the uptake across the facilities. And this is Metro. It's per district of how many people are actually physically in that, and that was as of the 9th of July. So just the last one is that red dot is from Public Works, and that is a taxi service that helps us to either to transport our own staff, but also to help us with moving people from quarantine facilities to and fro quarantine and isolation facilities. And then we are currently mobilizing very hard for increase in Q&I. We ask community leaders, we've asked ward councillors, we've asked the clergy from the religious sector, and we've asked basically community, everybody, to help and to spread the message in terms of improving the uptake for Q&I. Just an update on the testing then. Currently, there was a big session that we had, and our current testing is obviously healthcare workers, people in hospitals waiting confirmation, high-risk vulnerable groups, and then sporadic cases and clusters in rural as part of their containment. What we've added is we've added unexplained deaths and also testing for vulnerable groups, a specific one for diabetics. And currently there's no backlog of testing in the Western Cape. We're very mindful that if we start testing too widely again, that we get the backlog back. So we're titrating the availability of tests with adding judiciously what we want to do. Unexplained deaths, you can understand why it's important. We want to take test results, test samples, and send it for COVID of all unexplained deaths to make sure that we pick up all the deaths potentially linked to COVID, because deaths become such an important thing to track. And then diabetes is quite explanatory, because I'll show you now why diabetes is such an important thing. This is just to give the total number of people dying. And this is just to show you that the older you are, the bigger the risk of death. So that's the blue. Over 90, the chance, out of all the cases over 90, 23% of people die, as opposed to 75% that recovers. And you'll start seeing at 55 where this age-related mortality goes up. And this one on this side is also gives you a sense of the active cases, and this is age standardized. So what this means, if we take it for age standardization, you can see the risks are basically in that higher risk groups here. So because there are more cases down here, it looks fewer deaths over here. But if you take it proportional, this is what this does. For the proportion, and you assume everybody over 90 is exactly the same as everybody over 55, it shows you the risk for over 90 is much higher than over 55 because you've adjusted it for age. So that blue is then adjusted for age. But also understanding who, so if all the people that die, 52 had diabetes, and I made that point earlier, more people with COVID actually has hypertension, but proportionately fewer people die of hypertension compared to fewer people, the people dying from diabetes. So more people have hypertension with COVID than diabetes, but more people die from diabetes than from hypertension. So therefore, out of 100 people that die, 52 is diabetes as opposed to 19 for hypertension and 12 for HIV, and then kidney disease 9. So this is the diabetes report. It tells you of 7,053 diabetics. This is the distribution. And I just want to show you this picture. Now, if you take the general population, everybody that has COVID in this province, roughly 90% of people are not admitted. So the general population would be 90 and 10% would be admitted. If you take the diabetics, the 7,053 diabetics, 46% of them land up being admitted. That means if you're diabetic, your likelihood of landing in hospital is almost 50%. It's almost 1 in 2. Then if you take the recovery, of all the people that are admitted, 57, so that's about 60% of people recover, but 40% die. So this is significantly higher risk than the normal population of firstly being admitted, secondly having dying from COVID. That's why our attention sets to the Diabetes is the primary big one we're focusing on now. And that's why our testing is now about picking up diabetics earlier and dealing with them in a more sustained way. This is just to tell you why that risk is, and this is just to say all diabetics, controlled, uncontrolled, that's the risk of dying because associated with diabetes. I'm going to skip a little bit of this, Chairperson, if you don't mind, just to say to this, yeah. So what we've then done, and we've launched it yesterday, is to say that if you're high-risk diabetic, that means you're poorly controlled and you have risk factors, we will admit you to the convention center. So we almost like preemptively take people that is poorly controlled with diabetes and admit them and observe them and manage them more effectively than waiting for them to come to hospital. If you're moderate risk, we'll get that pod that I explained to you earlier to give you daily calls. So it's a medically qualified person that checks with you every day and wants you to take your blood sugar to check what your blood sugar is like. If you're low risk, the call center will call you every day to check in with you to make sure. And this is now what we want to say, what we call as a risk adjustment strategy with a special focus on diabetes, because we've seen the high associated risk associated with diabetes. Then to come to the health platform, the hospitalization seems to have stabilized over the past 2 weeks, around about 1,800 COVID-19 patients needing hospitalization. Remember, I made a distinction between COVID-19 positive and people that are PUIs, or persons under investigation, which is another 700. But for COVID, it's more or less 1,800. The Hospital of Hope, which is CTICC, and Tusong in Kailicha, they've really played a massive role in the last 2 or 3 weeks, because it's really allowed the acute hospitals to take the pressure of the acute hospitals. We've also done what we call a bed bureau system. Bed bureau system is, at any given time, we give you a snapshot of how many beds are available for COVID, how many beds are occupied. And the ambulance and everybody knows immediately where capacity exists. And it prevents going from one place to another place to another place. It's pick up, go to the place where capacity is. Brackengate will similarly next week, it's coming online next Monday, taking first patients. So if you add Brackengate together with CTICC, together with Tusong, it will significantly decompress the pressure on the other hospitals. This was that peak assessment that we spoke about the last time. And that was this is now the original one. The previous peak is the one that I showed you, the high peak. This latest peak is the longer, flatter peak. And actually what we found was what we planned for was actually relatively over-providing what the new peak is saying we need at the peak. And if you follow what we're saying, we're even getting less admissions than what the new peak suggests. So at the moment, in a sense, we have additional capacity in our system. And if need be, we obviously have the capacity, but currently that capacity is not being called upon. It's important to understand that the 550 deficit for critical care is still there. And that we have actually got two big things in critical care that has helped us. That is the high flow nasal oxygen, and the introduction of dexamethasone has made it easier for us to manage the critical care patients in the potential absence of these beds. But now you must remember, this was for the peak. So that 550 probably is not realizing, because the peak seems to be not realizing at the moment. This is just Hospital of Hope itself. Up till last week, it has had 847 admissions, 544 discharges, and 40 deaths just at the Hospital of Hope. This is the number of hospitals that used it mostly. You can see Grootskee uses it mostly. Mitchell's Plain, followed by Somerset and Victoria, and Helderberg, Eerste River, Karl Bremer, and Tygerberg more or less in equal measure. Kailicha will be less, because Tusong is right next to Kailicha. And these are the other smaller hospitals. And it just gives you a sense per week what our admissions are as being at CTICC. Brackengate will be now on the 20th of, as I said last week, next Monday. We will appoint 308 staff members. People have already got orientation. And just see by virtue of what we've done, We can also take 8 patients for high flow nasal oxygen even at Brackengate. We can take 4 at the CTICC. So the high flow nasal oxygen is really something that has really been a game changer for us in terms of dealing with it. This is what the Brackengate facility looks like. It's really a good facility. Really, we're all looking forward to the patients arriving next week because we've really done well in terms of what we've been able to pull together in that facility. And this is the point I'm making about critical care. We're still not getting all the beds, but we've got SLAs with the private hospital groups. We've put systems in place. We've got high flow nasal oxygen, dexamethasone. And actually, we've been able to manage people that require high flow nasal oxygen in acute beds. If you put all of that together, we've mitigated the risk of not having all the critical care beds. And actually, we can now almost tell you that we have contracts with the private sector for hospitals and groups. I've just signed with Mediclinic this morning, but we are not pressurized to use that in any big volume at any given time now. So then just the last thing about strategies for impacting on COVID deaths, it's the Khayelitsha one, differential, but it's the active management of diabetes. And then also to make sure that we follow all the other COVID patients. So there's a big lesson for us from COVID, is that the active management of people with chronic diseases for high levels of control is a big focus for us, because that's the one area that is people that's been at most risk because of COVID. Lastly, just to go on to behavior change, we've got quite a lot of public health specialists in our system. And the public health specialist skills is now being brought to bear. Now, public health specialists are specialist doctors, like you have cardiologists or pediatricians. We have public health specialists. And we're very fortunate to have quite a few public health specialists. They're able to describe, explain, and quantify health risks at an individual, community, and society level. They're able to design interventions that are evidence-based. They also can apply the principles of health economics, and they can also evaluate the research. But very importantly, they're very crucial for data analysis and interpretation. This is probably one of the biggest things that we would like to do, and really for this committee, it's the single biggest thing that we want the Western Cape to concentrate on for the next 12 to 18 months while we're still short of a vaccine. This is, I apologize, if you have your detail, you can go into a little bit detail, but if I can just quickly explain. That represents an infected person with COVID. Now, infection can happen 2 ways. The person coughs and they have droplets in the air, and you would have noticed there's some recent research to say it can also be aerosolized droplets, so it can stay in the air a little bit longer. That droplet, if somebody that is vulnerable, people that's not infected, can become infected if they inhale the droplet. That droplet can settle on a surface. If somebody touches a surface and it goes onto their hands and they put it into their nose or scratch their nose or their eye, they can become infected. The same thing from the infected person. If they sneeze onto their hands, they can put droplets on their hands. They can touch a surface. That surface put other people at risk. They can put it, touch, and then. So the whole idea here is to identify where are the breakpoints for breaking transmission. This blue bar is the solid bar of isolation and social distancing. So the big thing is anybody that's infected should be separated from other people. That's where isolation and quarantine becomes an important thing. Self-isolation at home becomes an important thing. But also the social distancing becomes an important thing. It's the distance between people. So that's where this, which is the big blue bar, number one key behavior is social distancing and isolation of sick people. Or let's call it infected people, then I might not all be sick. The second big issue is to break the cycle of putting droplets either in the air or on your hands is the issue of using a mask. So that is the gray one here. That's using a mask, wearing a mask. The third one here is actually coughing into a tissue, disposing it, coughing into a tissue, disposing it. That is cough etiquette and respiratory hygiene. Then there's an issue about washing your hands. So it's on your hands, wash your hands, then you don't put it on the surface. Washing hands becomes an important issue. That's hand washing. Then a very important one is to disinfect surfaces. That's disinfect surfaces. So that is cleaning highly used surfaces. And a very important one here, that's something that we all need to also get into, is do not touch your face, which is really avoiding touching your mouth, eyes and nose, which is called the T-zone, because if you have got an infected surface or you got it from somebody else, you can be infected that way. So these are the behaviors that we're seeking to influence. And there's now, we've consulted with behavior specialists and scientists. We're very fortunate again to have many high-level top scientists in this province, and they've advised us on the issue about what influences behavior. So it's motivation, intention, and the positive outcome is repetition. So one of the things that they actually said, the old approach is it's conscious. We all do things because we consciously want to do it. But most behavior actually is habitual and unconscious. So it's more of a habit. Most behavior is actually habit. So there's big things here. The habit is whenever we see people, we want to go close to them. This is the habit we have to break. Whenever we want to talk to somebody, we want to take our mask off because the habit is to talk without the mask. So many times you can see people, observe them, they wear a mask. The moment they want to talk, they slip it onto their chin or they take it off. Because the habit, people are not in the habit of talking with a mask. If people want to exercise, the habit is to exercise without a mask. If people touching their faces is one of the most ingrained habits. It's a habit of touching your face. So the point here is, what do we do to break these habits in terms of behavior change? There's been some research done. The research is all in here. I'm not going to take you all through this, but basically it is checking in the noon, Langa, who's wearing masks, who's not wearing masks. In Atlantis, quite interestingly, because somebody asked somebody to get onto the MyCity bus, you must have on a mask. People coming to the waiting area for the bus, all wearing masks. So there's an incentive of being requested to wear a mask. Outside this supermarket in Langa, two people wore a mask, and happened to be the security guard and somebody next to the security guard. Everybody else didn't wear a mask because the security guard was not asking people that it's a requirement before you come in here to have a mask on. So nobody was asking them. He was just checking their bags, making sure that people don't steal things. He was not asking people, actually, you can only come in here if you wear a mask. Obviously, the statement from the minister and from the president and the new regulations now changes this, and it helps us to actually require, before somebody comes into a place like this, that they should have a mask on. The interesting thing here about children in public are unlikely to wear a mask, but the moment they're in the classrooms, they are wearing a mask because they are expected and asked to wear a mask. And these are all the reasons. I'm not going to go. Everybody can read the reasons for why people don't wear a mask. It's not surprising that many people can't afford to wear a mask. So one of the things is, if you're poor and you are worrying where you're going to get your next food from, and there's a very disturbing statistic that comes out of some of the behavioral research, is that many people in vulnerable communities are now very concerned where they're getting their next food from. Then people cannot actually afford to buy masks. So one of the big things is the provision and availability of masks. Reasons for wearing masks and the frequency of washing. Again, if mask is such a rare commodity, you can't afford it, you are going to not wash it regularly, and if you only have one, and you are forced to wear it in certain places. So it's really about the frequency and availability. The next one is hand sanitizing and washing. Again, it is about what is the behaviors and the habits influencing that. And then the last one is the risky places where people go, where people are dense, and what is the risk of picking up transmission. So all of that together basically means that behavior change, we're going to have to look at a combination of education. It cannot just be communication. You can't just say to people, wear a mask, wash your hands. That's not going to work because that doesn't change behavior. It's a combination of that together with regulation to say you can't enter unless you have a mask. And more importantly, to enable people. So give them access to a free mask and model positive behavior for them. If you put the three together, we might have a chance of changing the behavior. And that's what we're now saying. Provide masks, and do what we need to do to change the behavior. There is a model, the Ubuntu mask, and we are promoting as many models that we want to explore to increase the availability of free masks and really step it up in a big way. Okay, so the big thing is masks. Focus on those high-risk issues, taxis, where people go for workplaces, where they go and gather, possibly churches, schools, everything, and that we all stay true to form, and that for the next 12 to 18 months, this becomes the big drive in the Western Cape. Then what happens after what is the post-COVID situation? We've checked on the 30th of June, and service demand has impacted on many different ways. So the trauma caseload, I've already explained that. Neonatal and maternity pressures have continued. Interestingly, the diarrheal surgery season has significantly decreased, and there's a reduction of deaths due to diarrhea. So the reasons are being explored, but you can imagine normally every year between February and May, we have a peak in diarrhea, but this year, somehow it's gone. And obviously people are speculating about why it is, but we are formally checking what the reasons are. But mainly the big issue has been the service response. We had to de-escalate services to prepare for COVID. And the message about staying at home, together with lockdown, has really decreased utilization as evidenced in our April and May data. So at the end of June, we looked at all of this data in detail. Our headcounts for total headcounts and for children under 5 has dropped significantly. Our HIV/TB screening and treatment has dropped significantly. Our immunizations has decreased significantly. There's also been decreased surgery for circumcisions, cataracts, and other elective surgery, and many appointments, obviously by design, was not followed. So all of that together means that there is a bigger non-COVID risk that is currently developing in our setting. The acute general and tertiary hospitals, there's significant backlogs in elective surgery. In Red Cross alone, 375 surgery lists is now in backlog, just because of what happened over 2 months. The procedures and the operations also now take much longer because of COVID precautions. So before we could just quickly get people into theater. Now it's hand washing, it's social distancing, it's all the things that we need to do. And big backlogs in taking x-rays and people going for OT and physio. Mental health is probably one of our bigger concerns. There's a decrease of about 20 to 50% decrease in people coming for mental health care services. So this is a very vulnerable group of people. And they've also been vulnerable for COVID because of the behavior disturbance that's associated with mental health. And therefore, we've seen a lot of people with COVID in the psychiatric hospitals that are mental health. There is also an anticipation from our side of people relapsing from the mental health condition. So I'm not going to go into all of this, but there is just to tell you, our headcounts in the metro has significantly dropped. Our measles first dose has dropped. This is people starting ART dropped. The metro TB dropped. Rural operations dropped. Rural cataract surgery dropped. Metro sexual assault cases dropped. So the interesting thing here is that even the reporting of sexual assault cases to health services has dropped. Whether sexual assault has dropped, that's another question. But the actual cases being examined for sexual assault has dropped. While at the same time, the deliveries actually has increased. So we've not stopped doing deliveries, but all the other things have decreased. So the proposed service strategy then is that we are maximally geared still for July, and now we are navigating this peak, but as you see, there's a bit of slowing. We are now doing significant detailed plans during the month of July. And our plan is to say from the 1st of August, how do we now get back to all that non-COVID things? And we really want to start with chronic diseases of management for diabetes, hypertension, for HIV and TB, child and women's health. And we want to systematically step up all of those things. And this systematic reintroduction and scaling of elective surgery over the next 8 months, considering that we have to live with COVID for the next 12 to 18 months, it's going to be a challenge. But we feel up to the challenge. We believe that the recovery of the healthcare delivery system to reach even our pre-COVID levels of performance in the short to medium will probably require a whole of society commitment towards universal health coverage. And we probably need to invest over the next 3 to 5 years to really do justice to get to a good performing healthcare system again. This is the UHC capability framework we want to use. We concentrate on how we render services, what governance do we put in place, what people and system capability we require, and more importantly, a learning capability that we learn. And I just want to leave you with those last comments. We've learned in the last 100 days. To learn has been our biggest asset. To concentrate on our people and being connected and to trust them and to support them and to listen to their anxieties has been our biggest asset. To be able to adjust how we render services has been a big asset. The ability to take governance seriously and make decisions has been a big asset for us. And so caring for our staff, making sure that we are there and that we're agile and we're responsive has been a big thing in this area. Then one of the biggest things is the use of data and intelligence. And really being able to use data intelligently to plan what we do has been a big thing for us. And just slowly, lastly, isolation quarantine, there's still a high rejection rate. Community leaders are involved. Our staff safety is still an issue. We're still engaging with organized labor religiously every week. We're building relationships, trust. We're going to our staff sessions. We're listening to staff. We want to understand their concerns about PPE and continue to listen and let them feel heard. And then old age homes, we've got a big drive towards old age homes together with social development. And we're working very hard to reduce the risk in old age homes. So in conclusion, Chairperson, we must continue to closely track the trajectory. We are cautiously optimistic that we are seeing a slowing of need and potentially a leveling off, but we're not resting on our laurels. The services and frontline staff are still under pressure, but not overwhelmed. And what we are doing is to acknowledge that they are exhausted. It's been 3 months of really working hard. And it's the most amazing people that work in our system. So we really hold our hands up and really humbly applaud what people have achieved in this province. We have started the process to address all the non-COVID implications, but COVID will be with us for a while still. So that balance of doing both, it's going to be a challenge that maybe not necessarily everywhere else in the world people have had to take on. Our context means that we have to go there because we cannot ignore immunizations or mental health or HIV or TB. We cannot ignore it for longer than 2 or 3 months. It's going to be too much of a backlog to make up in terms of this. Obviously, our staff need to be physically, emotionally, mentally supported. We have these sessions. I had another session yesterday with managers. We had a session reflection with organized labor last week, which was the brilliant session with our colleagues, our social partners. We had a session with managers yesterday, and tomorrow I'm having a follow-up session with nurse managers. That's probably taken the brunt of the emotional strain over the last 3 months. And then sustaining and institutionalizing the gains we've made in the last 100 days, especially in terms of being agile, responsive, the relationships that we've built, the resilience, the stories of people helping one another, lending a hand, making sure that everybody works to a common purpose. It's been phenomenal, and that's what we can build on. Chairperson, thank you for indulging us for this long input. Thank you so much.
Thank you very much, Dr. Cloete, for the presentation. I think we'll have a quick leg stretch before we move into the questions. So if we could all just stay on the line, but put your cameras and your microphones on mute or turn them off. And then we will reconvene in 10 minutes at 23 minutes past 2. And we'll start with a round of questions then. Thank you very much.
Thank you, Chair.
So our committee will now resume. I'd like to thank Dr. Clitty for having prepared the presentation and for the information. It does look very hopeful. I'm now going to hand over to members in order for them to pose questions. I just want to make sure that we're all back on the line. Dr. Clitty, are you and your team on the line?
Chairperson, we are all here. Thank you very much.
Excellent, thank you. All right, so we will proceed in our usual manner, where I'll invite parties to pose questions for 3 minutes. We will have several rounds as we've got quite ample time for this meeting. So as usual, I'm going to start with the DA. Are there any questions from the DA? Each party will receive 3 minutes.
My hand is up, Chair.
Thank you, Honourable Philander. Please proceed.
Thank you so much, Chairperson. First and foremost, I want to echo your words in thanking the department for their commitment and dedication. And I must say, Chairperson, I'm very grateful to be residing in the Western Cape and elsewhere in the country. And that is not a political statement, it is indeed a fact. Chairperson, I would like to ask through you to the department in terms of their collaborative approach when it comes to education and to transport. We have seen over the past few weeks a great concern for the safety of learners. We have also seen in the amended regulations in terms of transport, taxis specifically, 70% for long distance and 100% capacity for shorter distance. What is the department's take on that two issues? And then also, Chairperson, what is the status of the field hospital outside of the metro? When will that hospital be occupied? And then I would also like to know in terms of the staff complement, in terms of contraction and fatalities, is there a concern from the department that at a certain stage we will not have enough staff to man our facilities? And Chairperson, my fourth question, in terms of the Cape Winelands district, screening, testing and tracing scenario, I know there has been a period in early July where there has been a change in focus. If the department can kindly enlighten us on that scenario as well. And then my last question, Chairperson, what interventions has the department taken in terms of other state departments, for instance, the police services and correctional services, as we have seen a high amount of infections in that instances? That's my questions for now. Thank you, Chairperson.
Thank you very much, Honourable Philander. Well, there's only a few seconds left of the time, so I will then move on to the ANC. Does the ANC have any questions, please?
Yes. Yes.
Honourable, please proceed.
Thank you very much, Chairperson. I would also like to echo our thanks and gratitude to Dr. Kluti, Vallabji, Engelbrecht, and also Karim. I'm not sure if I'm correct, but in the way that I saw Dr. Kluti, he looked slightly more relaxed than possibly he has been looking recently. And I hope that's an indication of the fact that the department, is able to deal with the pressures which are many. I'd first like to just ask for a little bit more detail on the status of health workers, both in the hospitals as well as the various clinics. We have been concerned at some of the issues related to management, particularly at Tygerberg Hospital, and to some extent at Groote Schuur, where a lot of tensions have emerged with the unions and the ordinary health workers in regard to issues of management, and these have led to some conflict situations over the last months. I just wanted to get a sense of exactly, because I saw it was up on the slide, exactly the number of infections and the number of deaths, and I'm not sure if that can be expressed as a percentage of the total number of health workers in the province, and whether Dr. Kluti and the team believe that the management issues at Tygerberg have been addressed. He did mention that there was a successful meeting with the unions. I would just like to ask that. And then secondly, on the issue of tracing, there was quite a informative slide about the role of community health workers and what they are doing. But and also, as far as I understood, the issue of using technology in regard to the issue of tracking and tracing. I just wanted to have a bit more elaboration as to whether the department feels that they are on top of the issue of tracing. And then in regard to the information provided, there's been detailed information about areas, but does the department have this information broken down to a ward level? Is that information available? And if so, can it be shared with the committee?
Thank you.
And then I would also like to ask, in regard to the figure, I'll wrap up, the percentage of infections per 100,000. How does the average percentage of infections per 100,000 compare between our province and the province of Gauteng, KZN, and the Eastern Cape? Thank you, Chair.
Thank you. It doesn't seem as though we have any representatives from the EFF on the line. If there are, if you'll just correct me. If not, we'll then move on to Good.
Thank you, Chair. I'd like to start with some questions around hospitals and hospitalisation. Let me just ask that, first of all, the Hospital of Hope at the CTICC, I recall the committee being told that that was a facility being provided rent-free, but there are posts on social media that is now costing 24 million rand a month. That may be fake news. I just wonder if Dr. Kluti could confirm whether there is a charge, a rental fee for the use of the CTICC. Then just on hospitals and capacity, I'm a bit confused by the information that we were given. I mean, the alcohol, the impact of alcohol, the suspension of sale of alcohol was quite compelling. And then there were conflicting information, as far as I could tell, on hospitalization and capacity. Because on the one hand, we heard that the hospitals are not pressurized. On the other hand, the impact of trauma cases seem to put pressure on hospitals. So I wonder if Dr. Kluti can just clarify what appears to me to be a conflict between the information he provided on hospitalization and capacity. Then I remain concerned around contact tracing. I've been raising it for several months now. Yesterday, we got a report from the department that showed that between the 2nd, I think, and the 9th of July, there was about 10,000 new cases. That's about a week period, and that there was an estimate of 20,000 contacts that were traced. And we've just seen the slides now where there 32% of the call centers unanswered. So it seems to me there's two problems. First of all, that we have an estimated number of contacts traced rather than an actual number, and that we're still only reaching about 2 contacts per positive case. And then this unanswered calls worries me. So, I mean, are we getting on top of contact tracing, which is a critical part of the health protocols? If I may, do I have some time, some more time?
You have about 40 seconds, so yes.
Now I'll just ask, I was concerned about the introduction where we saw the difference between the different districts and the HIV and younger patients in Khayelitsha. And I wonder if Dr. Kluti could explain why the HIV is regarded as a comorbidity in younger patients in Khayelitsha. My understanding was that HIV was only really a heightened risk factor if patients were not on treatment. So does that mean that there's been a lapse in treatment in the Khayelitsha district? If you could just explain that relationship. Thank you.
Thank you, Honourable Heron. I don't think we have a representative from the ACDP on the line, so we will then move to the Freedom Front Plus.
My questions basically, one of it ties up with the one asked by Honourable Member Dugmore. He wanted to know whether we can zoom into where incidents of this COVID virus is most prevalent per ward. You see, I want to know whether poor nutrition and poverty, there's a correlation between that and the survival rate of people, or the tendency to get infected. Does that play a role, and to what extent? If we say Tygerberg or Klipfontein, Tygerberg is very big. Where in Tygerberg? Where in Klipfontein? Let's zoom in so that I can see what are we talking about here. The second one is, they mention that people with diabetics and hypertension, they're more vulnerable for the COVID-19. Now, I would like to know, could you tell us whether the people who's got diabetics or who have hypertension that attracted COVID-19, do they have private medical aids, or do most of them depend on the government hospitals for their medication, or their chronic medication? We've been to Lensburg and we heard there that there was no chronic medication for months at that old age home we visited there. The committee went there. So then the people have diabetics, which is not under control. And so it's not actually the fact that diabetic is the cause, it's because it's not under control. It's not under control because the state didn't give it the people the chronic medication they need. I want that figures. And whether poor nutrition plays a role. And also I would like to know whether medical aid or not medical aid has a role to play here. Because people who can't afford private medical aid subscriptions, they will not have medication for diabetics. So it's not the fact that they have diabetics, it's because they didn't have chronic medication. Can they please explain this to me?
Thank you, Honourable Murray. That then is our first round of questions. Honourable Dugmore, if you turn off your camera, please. Then Dr. Kluti, I'll hand over to you to respond. Thank you very much.
Thank you very much, Chairperson. So I will do the best to quickly respond. And if time allows, I will ask one or two of the colleagues just to add elaboration. Just on the first set of questions, the collaboration approach, there's an overlap between that and a question about what is our role with other sectors. In our management team, Dr. Engelbrecht has got a specific role, and that is to work with other sectors to guide them and to provide public health expertise and advice to other sectors in terms of COVID. So in relation to that, we have played a, let's call it, advisory role in relation to that with education, and also an advisory role in relation to transport. The two specific things that are being referred to, which is learner safety, is a broader concern about safety, which obviously all of us are mindful of. And obviously we are very much concerned about the fact that safety is a big challenge. And then the second issue that was raised is the issue about taxis and the regulation that talks about 100% occupancy with open windows. In terms of public health, it is very clear that our Department of Transport and Public Works, when that draft regulation was mooted as a possibility, made appeals, and we also made appeals to the National Department, that for us is a big risk in terms of transmission. So we are not supportive of 100% occupancy in a taxi, because we do believe that that is quite a risk in terms of for social distancing and transmission in confined spaces. Just in terms of status of field hospitals outside the metro, Soonstraal is in Paarl. It's starting to have some additional capacity, and we're starting to admit patients into Soonstraal. What we also have done is in Hermanus, in Swellendam, and in George at Harrikomay, we've created additional capacity, which is much smaller, but it's really capacity for being able to deal with the impact of COVID on hospitalizations in those areas. And in Worcester, we have specific arrangements in relation to the TB hospital and reorganizing bed capacity in the Worcester area. So we have, in addition to Soonstraal, these local arrangements that we put in place. Just in terms of staff, I think it's quite important to make the point around staff that when we were planning for a very high peak and also a high infection rate among staff members, we made calculations ourselves that staff shortage will be an important consideration. There's a fact of two things. I'll come back to it also later when I respond to Honourable Heron's question. There's two factors here. The first one, firstly, the peak is not as high as we expected it to be. And secondly, the staff infection rates also have tailed off. I'll give the explanation to Honourable Dugmore's question when it comes to the staffing figures. So because of those, our staff leave due to staff taking leave due to COVID has been lower than what we projected. And what we're also now doing is, because Convention Centre in Brackengate, we were predicting to have those facilities full, we are in a position to be able not to fill all the staffing posts that we wanted to fill in those places. So it's a combination of all of that. It means that our staff is under pressure, but as I said, not overwhelmed. We also have sufficient staffing, and we are coping at the moment in terms of what it is we're facing. Then in terms of fatalities, I'm assuming the question would be, can we cope with the fatalities? I think part of the issue is we've got a facility at Tygerberg that we prepared in the old CDU building to be able to take, if there's an increase in fatalities. We've done that together with the City of Cape Town. Again, our numbers are less than what we expected. Therefore, we have got the facilities to be taken to take bodies in, just in case there's a lot of bodies in terms of dealing and processing them. And we've started taking the first couple of bodies in last week in terms of this mass fatality center at Tygerberg Hospital. In terms of Cape Winelands, just to explain, early July, what happened in Cape Winelands is very similar to what happened in the metro. So there's a correlation between the two. And again, because screening and testing, and I think I said that the last time I was at the committee, we did community screening and testing at the same time as clusters being evident in this province. So what happened in Cape Winelands, again, there was quite a few clusters that they were responding to. So they also had a focused and targeted screening approach because they were investigating clusters. And at the same time, they were also very concerned about the vulnerable people as in the metro, and then focused their attention on not just clusters, but also focusing their attention towards the more vulnerable people. And therefore, the testing regimen also was tightened up in that specific regard. So that is a very similar picture of what has happened in the metro. It has stabilized in Cape Winelands as well, the numbers. And in terms of testing, it's the same pattern that we're doing in the metro. In terms of the interventions with SAPS and DCS, I will come to the end and just ask Dr. Engelbrecht just to have a quick response, because we've done a very good engagement with SAPS and DCS. I'll just quickly go through the others and I'll come back to Dr. Engelbrecht. In terms of the questions from Honourable Dugmore, just in terms of healthcare worker status, again, Honourable Dugmore, as of last Friday, the figures that's commensurate to this report, obviously there's been more infections since then, but I'll give you the figure as of last Friday. Last Friday, we had 3,939 people, healthcare workers, infected in this province, of which 647 was at Tygerberg Hospital and 474 was at Grootske Hospital. Again, it's the two biggest hospitals, and that is 3,939 is for all the healthcare facilities in the province, including private sector. At that point, 780 of these cases were active. That was 19%. 33 healthcare workers had died at that point, and that was just about 0.83% of all healthcare workers positive have died, 33. And of the 33, 16 of them were nurses, and there's a breakdown of where the 33 have died across the facilities as well. The vast majority of people that were infected, which is 3,126, which is 80%, have recovered by then. So at that point in time, we were sitting with 19 active cases, 780, 0.83% of people having died, and 80% recovered. If I can then go into the specific question about the management challenges or the reported, let's call it friction, and the reported challenges reported from organized labor in relation to management at Grootskei, Tygerberg and other facilities. Part of what I indicated to Honourable Dugmore is that we have a weekly engagement with organized labor, and that's the members from the chamber. And one of the things we do there is really to discuss, do we find one another? Do we find respect? Do we have a good working relationship? Do we understand one another? One of the concerns raised by our organized labor challenge colleagues is, does that translate itself to institutional level? And the issue that was raised specifically was Tygerberg, and we all agreed that we will have a mediated process, that all the parties agreed. We will come in, send the external mediator, and between management and organized labor, we will mediate the process. So I'm in the process of getting agreement with our organized labor colleagues to say that there's a mediation process so that we can get to the bottom. Everybody wants the relationship to be repaired, to be healed, to deal with the issues and move from there. Similarly at Grootskei, there were some concerns raised, but you would have noticed, and I'm sure you would have heard, that the national office bearers of NAHAO came to visit. They went to Grootskei, they went to Tygerberg, they went to Victoria Hospital, to Somerset Hospital, Mitchells Plain Hospital, Kylie Hospital. And actually, by and large, our reflection with organized labor was that the findings from the senior leadership of NAHAO that came to visit was actually there is a relationship here between management and organized labor. It may be strained in certain places, but it is a relationship that we're all working on, and all the parties are committed to work together. So they were actually quite pleasantly surprised by the levels of cooperation and the commitment from us as management to work with organized labor to solve these problems. And we continue to be true to that commitment. Part of the meeting tomorrow of having a reflection with all nursing managers is that organized labor is formally part of that reflection. So the senior shop stewards, especially of all organized labor parties, actually participates in those reflection sessions with us. Then in terms of tracing community, with community health workers and the track and tracing, and I think it's a little bit the concern that Honourable Heron also has, is we can tell you where we sit now, where we are now in July with the number of cases. And I just want to put the context in this. Track and trace is a software system which now enables us that as somebody gets tested, whether they're negative or positive, they can enroll onto a software system. It gives us access to that person. So it's a platform. That platform we did not have in May. We have that platform now. We've been piloting it since June. We're rolling it out for the rest of the province. In July, we actually have good coverage. And out of that platform, we have an avenue to be able to get to all positive cases and possibly their contacts without having to give them a call, because we are communicating with them via a WhatsApp mediated platform in terms of that. So I think that's a big advance, and it's something that in the country would also be a big advance. In addition to that, we have the community health workers, we have the PHC facilities, we have the tracing teams in each sub-district, as I explained, and we have these pods, which is like specialized team. And on top of all of that, we have the call center that now takes up to 1,000 calls. So you need to put all of that together. And from where we are now, we've never been in a better place than we are now to be able to say we endeavor to contact every single person, index case that's positive. But as Honourable Heron says, there is still the concern about the wrong numbers and people not picking up. That is something that we're putting into that entire system. So if you ask us, our mechanisms, we have the mechanisms in place. We need to be able to learn from it, deepen it, and we are really, really, really endeavoring to make sure that we get on top of being able to contact people that are positive, being able to get in contact with their contacts, so that we actually have a communication platform to work with that. In terms of the ward level detail, that's, yes, Honourable Dugmore, it is available. We now have institutionalized a system that every Friday we release the ward data, sorry, the data that we have that we show you on the daily report of exactly 1 week before. And I will explain to you why we release it every Friday at ward level, a week in arrears. It is a little bit because of the problems with address data. So there's a lot that comes because we only get a positive test from a lab form. It's about verifying the address data, making sure that it's correct address data, phoning the person, at least getting a hold of them to confirm. So we need at least a week lag time to make sure that if we're going to release ward level data, that it's accurate. Because the worst thing you can do is you release it then and everybody says it's not accurate, the address was wrong, it's in the wrong place. So that cleaning up of the data, which is a week, we're now in a rhythm that every Friday we can release cleaned up ward level data of at least a week in arrears. And we continue, our intention is every Friday to release that. If the committee wants access to that, that's definitely something that we can make available to the committee. Then the question about percentage of infected cases per 100,000. There's two challenges with cases per 100,000. The first one is that a case per 100,000 is on the basis that we already know that we are not testing for all potential cases. So there's already a limitation of what proportion of positive people you're actually testing, let alone, so it's only tested cases per 100,000. So if you read it with that limitation, there is a comparison cases per 100,000 in the last 7 days. That is a comparison that we can do with other provinces. I must say I've not done that comparison myself because that is what the NICD does, or the National Department. I definitely can inquire and ensure that that formal comparison gets made available. So I will inquire to find that comparison with Gauteng, Eastern Cape and KZN, especially the last 7 days, and what is the comparison with the others. In terms of Honourable Heron's questions, the first one, Honourable Heron, Hospital of Hope, I can confirm with you that the original hire agreement is from the 4th of May to the 17th of September. And that hire agreement is for 36,443,000, so 36,443. And that is on the agreement reads the following. It is 100% discount on venue rental. So there's zero for rental in that agreement. The cost of that 36 for that entire period, 4 May to 17 September, is for the staff cost of CTIC to keep the place running so that we can run a hospital. So it's employing the people to keep the place going. That's number one. Second one is for waste management. The third one is for cleaning and cleaning consumables. Fourth one is for the electricity and the water. Then it's to operate lifts, generators, pests, plumbing, safety, CCTV. It's also to get the parking base. So we're getting parking base at 50% discount rate. So it's getting parking base. It's laundry costs. It's to decontaminate the place afterwards. And then it's catering for patients, which is 150 Rand per day per patient. All of that together is for the whole contract period. Was projected to be 36,444,000. So I just want to put that in context. We have paid 36,212 today, and the idea is the variable cost is being looked at in terms of that. Just the second thing, and that's to use the venue. Then in addition to that, we then had to, having got access to the venue, had to construct a hospital at very quick time. In 3 weeks, we constructed a hospital. That is a separate contract with Scan Display and that was for 10.197 million to build the hospital, to put all of those things up, and also to have some items that can be hired per month. And to date, we've paid 9.9 of that. That was for installation, for all kinds of things to date. Then on top of that, obviously now we have a hospital, it's the operating cost for running a hospital. That's getting the oxygen, getting beds, equipment, and all of those kind of things. So just to clarify that the first one, which is it's the contract it's the hire agreement to use the facility, has got zero rental in it, but it's to cover the operating costs for keeping the convention center going for us to be able to operate a hospital on the inside. In terms of the capacity in hospital, you're very right in your observation. And I think the point I'm making is that we as the healthcare system are acutely aware of the impact of alcohol. Now, alcohol, when it was restricted, that's the slide. In that period restricted, we had a 50% reduction in EC visits and all of those. When the alcohol restriction was lifted, and that is into the first week in June or for the whole month of June, the impact is there was a 50% increase. Now, that first week of June, the ICU, the number of people that were from trauma that in lockdown occupied an ICU bed was only 2 or 3 people per day for an ICU bed, and it went to about 9. So I'm saying that in the first week of June, 7 additional ICU beds were occupied with people with trauma-related things that wasn't there when alcohol restriction is there. That's the only observation we can make. That was at the time when we still had the reasonable pressures and we still had to look at all our capacity. What we've seen since the beginning of June till where we are now, the second week in July, is your observation, is we've seen a lightening of the COVID needs and our capacity now. We have spare capacity because we have provided for capacity that didn't necessarily realize in terms of hospitalization. So your observation is absolutely correct. And just to make that, to clarify that is a distinction. So I'm clarifying the facts as it is for you. Having the alcohol restrictions now, which is a decision that was made by the National Command Council, foreseeably will have an impact on healthcare provision. It is just that at this point in time, it is not as if alcohol is pushing out COVID as we speak. And you're absolutely correct that it's a timing and what all of those messages come together. Then on your last point, I think the issue about contact tracing, you rightfully have been asking us for the last couple of months around this issue. We are really, in a sense, contextualizing the contact tracing. So you're right, between 2 and 9 July, there is the number of positive cases, 10,000. Then there is this projected. Now, the projected I explained to you, and that is what Dr. Moodley gives you every week. It is projected on the basis that we are taking what is happening in the call center, we're taking what's happening in each sub-district, and we're making a projection. What we are in the process of doing, which I asked Dr. Moodley now, is we want an accurate quantification of the actual number. So we have to put a data system in place. Now, that data system we are going to now put in place, and we're going to try and retrospectively make sure that we can call all the data elements together to be able to give a composite picture of that. But I agree with you. It's less than desirable to have a projected figure. And then secondly, there is a concern about the numbers, the percentage of people that's not answering their phones. And that is a system that we want to close, which takes us back to track and trace. Because what we want to do is to see if track and trace on the point of getting your test results in people giving the accurate cell phone number the first time around. Like I said, there's a good example in Mitchell's Plain where they actually got an incentive for that because the person there said, look, we're going to contact you, we're going to support you, we're going to give you things. And therefore, that intervention seemed to have been that in Mitchell's Plain, there is less wrong numbers or people not picking up different numbers. So we are very much wanting to fill the picture for us on contact tracing to actually get all of those together. And then just lastly, your question about HIV and younger people in Khayelitsha. So maybe just to contextualize. The first thing, the point I make is that for everybody that's COVID infected in Khayelitsha, unlike the other sub-districts like Klipfontein and the Metro generally, the first two biggest comorbidities is not hypertension and diabetes. The first comorbidity amongst all the positive people is HIV. So there is for compared to others, there is a disproportionate number of HIV positive as a comorbidity with COVID. It doesn't say anything about their predisposition for being vulnerable for hospitalization or not. It is just that. And the factor is that when we look at the age structure of Khayelitsha compared to Klipfontein, it is a younger age structure that is responsible for that. But the diabetes and the hypertension is still, if you do age adjusted, is still the same risk in terms of Khayelitsha and Klipfontein as a comparison. Then just the last questions from Honourable Marais. Honourable Marais, if we do give you the ward data, and the ward data is very clear, it points to two very specific things. When we look and you quoted Tygerberg as an example, so I can give you the Tygerberg examples because I've been part of that hotspot discussion. In Tygerberg, if you break it down, the biggest area of where the ward and the suburb breakdown point to, the biggest area there is vulnerability in Delft. That's much bigger than it is in Bishop Lavis, than it is in Bellville South, but that is and Belhar is then after that. But you can clearly see pockets of greater vulnerability for COVID, and the overlap between that, because that's what the colleagues have done. They've done a comparison with what we call a socio-economic vulnerability index. So if you overlay on a map where people are living from a vulnerability perspective, that's poverty, crowding, lower jobs, and all of those. If you put all of that together, and you overlay where the cases are for COVID, it happens to be in the pockets of higher vulnerability. So that association is actually in the data. So if you break it down, you can see that association very clearly. You ask a very important question whether poor nutrition is associated with it, and I think that's something that we need to explore further. Just to look at, and I would assume that socioeconomic vulnerability and nutrition runs together. So again, the question would be probably right, that nutrition and socioeconomic vulnerability is a prerequisite or a vulnerability index for COVID, but it's also vulnerability for hypertension, for HIV, for TB. It's all the comorbidities are likely to be because of that. Then your last question, diabetes and hypertension, definitely, sir. The majority of people that is diabetic and hypertension is dependent on the public sector. That's the majority of the people. And because of our data system, we actually know when they have been diagnosed as hypertension and diabetes. That's why in the Metro, we could deliver their medication to their home via the community health workers. So we actually have a very extensive system. But you're right, there is vulnerability again with people that are diabetic and hypertension. And the question is, we know from COVID now, and we know from our history before, and that's why I said our focus going forward is, if COVID has taught us one thing, is people with chronic diseases are more vulnerable, but also we need to look at their access to chronic medication and look at their access to be able to be controlled for their chronic disease. So that's a focus that we really have to put our energies in going forward. Dr. Engelbrecht, if you can just give a feedback on the interaction with SAPS and DCS, please, Dr. Engelbrecht.
Thank you, Dr. Kluti. Thank you, Chair. So perhaps just to take a step back, when the epidemic started very early, we were very watching the data that came through, and we could see that there are certain sectors that are quite impacted upon. And we then early in the epidemic then realized that we need to have some focus on other sectors, and that was one of the tasks that I then took on. The first Brandvlei prison in Worcester was in the very early beginnings. We could see traces. That was before we had community transmission. We saw that there was we could trace by contacts, from the Cape to Worcester to Witzenberg. I mean, just very clear, unless we contain, and we were concerned about prisons, unless we contain, we might have a risk. So we then made contact with our prison correctional services, and the principle that we follow is that we build on existing relationships. Now, the Department of Community Safety do have existing relationships with both SAPS as well as correctional services. So they worked together with us, and the intention is that after COVID, we need to have established relationships that will continue in the future, and that we will take that forward. So what we then engaged with, so Regional Commissioner Klaas and Geraldine Pienaar has been very instrumental in our engagement. We visited Paulsmoor Hospital to get an understanding of what is the risk assessments that's happening there, and also to get a better understanding of where offenders are kept, to what are the risks there, and what are the measures that correctional services have been put in place. So we assisted them with risk assessment. We assisted them then with developing guidelines, so that the guidelines could be appropriate to the latest information. We realized that we've got public health expertise, we've got occupational health expertise, and that is a privilege that we have, and we need to make sure that that is available to the other sectors. And I must say, the guidelines that we assisted correctional services locally with, they've taken that to national, and it seems like it's also informing the national processes. We've been working with training of the doctors at Paulsmoor in the management of COVID. And the last, we are meeting tomorrow morning again with correctional services. And the last figures that we've got is that there were no new infections. We are very proud of that relationship, but also the capacity and the way that correctional services really stepped into this place, and that's really good leadership there. As far as SAPS is concerned, we also followed the data, and I think more particularly the frequency by which SAP stations closed. And we realized that the evidence now is that you don't have to close a whole place if you just want to clean a spot. And we then also engaged with the Provincial Commissioner Matakata through Department of Community Safety and her team, Brigadier Voskale and the colleagues. And then we again sat with them. It does appear that their occupational health and safety capacity is more at a national level. So we worked very hard with them locally to build their occupational health and safety capacity locally, and to also assist them with having guidelines that is kind of relevant and easy to follow. And I believe that that was also General Becky took that also to the national side. So for SAPS, we also had training sessions with some of the stations, especially Somerset stations. There were some of them that closed the third or the fourth time. We had a kind of a virtual training session by which we went through all their questions and answers and explained how to prevent, when there's a case, what to do, when you clean, what you clean, how, when you close, etc. And again, we feel very very proud of them and the way by which they've taken up the opportunity and grown their own capacity, taking that forward. There are a few training programs coming up, and we're also developing an electronic training program that people can train themselves in COVID. I think the most important thing is COVID is going to be with us for the next few years. And unless we build capacity now in all our sectors, we will not be able to maintain a standard of safety for our employees, but then also for our communities. So I think the philosophy that we followed is to work on existing relationships that provincial government has with these sectors. For example, we also worked with the agricultural sector through the Department of Agriculture, the public transport through the Department of Transport and Public Works, and all retailers and Telkom and Eskom and all of those through the Department of Economic Development, so that we strengthen current or pre-existing relationships. And the main focus was, if these are employers, and employers have to look after employees or the clients, and to what extent can we build capacity that will also be useful for the future. We also have to think of TB. We also have to think of other diseases or infections that can happen in any workspace. And let us rather build capacity from that long-term perspective. Yeah, so I think that that covers the aspect. Thank you very much.
Thank you, Dr. Engelbrecht. Dr. Klutty, are there any further comments?
No, thank you, Chairperson. Just to say thank you to Honourable Dagmo. I am a bit more relaxed, and many of the staff in our department are a little bit more relaxed. We're taking good stock of where we are. We feel energized, and we really feel that we're ready to take on whatever is in front of us. Thank you.
Thank you. We do have time for another round of questions. So I'm going to afford each party another round of 2 minutes each, starting with the DA then. Are there any questions from the DA?
Yes, Chairperson.
Thank you, Honourable Mackenzie. Please proceed.
Thank you, Chairperson. And thank you to the HOD and his department and the health workers for all their hard work during this difficult period. I just wanted to find from the HOD that WHO and several experts are suggesting that a disease can be airborne or being in the air for extensive period. And what is the department's view on that? And have they discussed this with an expert? And have their plans, have they factored in a health response to this? Because obviously more serious. And then wanted to check is whether it's possible that this current dip that we are in, is it a step on our way to a surge? And if there's a significant change in behavior, wearing a mask, washing our hands, adhering to safety regulations, can the curve be shorter or the plateau be shorter and not towards the end of October, as you explained? And when we're employing quite a lot of people in the field hospitals, and I just want to get an idea, where are the funding coming from? Because we saw in the latest budget, there wasn't any funding coming from national government. And what is the latest on the PPE for nurses and healthcare workers? Are they enough? Are they issued regularly? Is there due to a lack of PPE and the healthcare workers being affected negatively? And on the community screening, I've been privileged to be part of that as well in Mitchell's Plain. And is there any private companies being used and being paid for the service, or are these just our healthcare workers? And then just a final question, how many of the people, or has there been any studies done on those with diabetes or whatever other, or with any other comorbidities, in terms of how many of them were heavy smokers, for example? I'm trying to get an understanding as to what the impact of smoking was on those number of people that unfortunately fatally passed away. And the last question, with regards to our facilities, our Q&I facilities, what is the protocols and guidelines with regards to those facilities before and when people are in those facilities? And if you can send us a formal document, if you have it, like how many times a meal do they get meals? Are they trained to inform people when their loved one pass away? First, condolences to the people before they just break the news to them, and do they give counseling? If you have that in a document, you're welcome to send that through to us. Thank you, Chairperson.
Thank you very much, Honourable Mackenzie. I'll now move on to the ANC. Are there any questions from the ANC?
Yes, Chairperson.
Honourable Nkondo, over to you. Thank you.
Thanks, Chair. My first question is on the Red Dot project. Given what the HOD has indicated about, the challenges as it relates to people responding to being quarantined, and the relationship of this particular project having been established for that particular purpose. I just want to know how much now, as we said, is this service being used to full capacity now that people are actually not, interested in the main, I think, to take up the quarantine spaces. The second one, Chair, is that I'm trying to understand in terms of capacity, especially in clinics in the hotspot areas, what is the level of pressure in as far as infrastructure of these clinics are concerned? I'm raising this because, as an example, in Gugulethu, one of the things I think.
Honourable Nkandla, we've lost you.
Can you hear me?
Yes, now we can hear you. Thank you.
Okay. My apologies. I was asking on my second question after the red dot one was that the infrastructure of the clinics that are supposed to feed into the health system, is it enough? Is it appropriate? As we know, even before COVID, we had challenges. I'm making reference that the clinic in Gugulethu was established and constructed in 1972. And the reality now of the pressures is that, you know, it is unable to take up that. And what is any solution, if any, now that there is pressure of COVID that is being placed on infrastructure, capital infrastructure, especially on those clinics that must assist now with the additional burden of COVID. The third one, Chair, is that in terms of the hotspot strategy, again, working with the local structures, I'm trying to understand whether in all the 8, if I'm not mistaken, in the city of Cape Town, hotspot areas, do we have, you know, these multi-stakeholder local structures, you know, like I've seen in Khayelitsha, I think there's one in Gugulethu and Langa, I'm not sure in the other areas. Do we have all these local strategies, or once again, we have a government-led response, you know, which indeed, I think as it is indicated there, if the communities are not coming on board, some of the behavioral issues are going to be very difficult, you know, with all the advertisement and all the other exercises. My last one, Chair, was to check.
We're just over the 2 minutes. If you'd then just park that question for the next round, please.
Thank you.
Thank you. I then move on to Good.
Thank you, Chairperson, and thank you to Dr. Cloete for the answers. I must say I was a bit surprised. I'm surprised by the answer on the CTICC, because I really, when I heard rent-free, I would have expected that rent covers operating costs like staff and waste and electricity and water. So I assumed that that was literally rent-free. So now it seems like we're paying 9 million rand a month to use that facility. So I wonder, are there similar costs for Mupine and Brackengate? If you could give us some indication. And then if I go back to the presentation on the containment under Q&I, there was a note that some people were previously not offered Q&I or public facility Q&I because it was only previously offered to specific cases. So I wonder if you could explain what the specific cases are or were who were offered public Q&I facilities. And then on the barriers to communities accepting space in public Q&I facilities, there was one note which he didn't unpack, but it said one of the barriers was that they do not qualify medically. So I wonder if you could explain what that means. Thanks so much.
Thank you, Honourable Heron. I'll then move on to the Freedom Front Plus. Honourable Marais.
Thank you so much, Chair Lady. Yes, what I found quite interesting is Dr. Cloete made an excellent presentation, must compliment him on it. Very scientifically based and very clear as to what's going on. But he's the one who kept on touching his face, you know. The whole, watched him on video, he couldn't resist sitting with his hand, with his under his chin and touching his face. So I want to ask, is it not time that we tell people, wash your hands and wash your face? Because we never tell people to wash their faces if they must wash their hands because the hands touches surfaces. Shouldn't they wash their faces also because they touch the surface, touch the face again? And then I would like to know, are clinics or day hospitals sufficiently stocked in terms of chronic medication? And is there oversight to make sure that's the case? The people who died of COVID-19 with diabetes or diabetics being the underlying cause. Were they aware that they are diabetic? Did you check? Or did they only find it out now that they were examined by the hospital doctors and told that the sugar levels were too high? Were they aware? And what are you going to do about it to create an awareness about diabetics, the same as you did the awareness about HIV? We spend millions to make people aware of the consequences of contracting HIV. I haven't seen any TV advert about diabetics. What is the health department going to do about this? And then I would just like to know.
Time has expired. Honourable Marisa, if you just park that for the next round. Thanks very much. Dr. Kluti, I'm going to hand over to you. Thank you.
Thank you, Chairperson. I can't resist not starting with Honourable Maria's feedback. You're so right, sir. I'm very much aware of my habit of touching my face. And I think that's part of the behavior change issue. It's the stuff that we do instinctively and others, and you might not be aware that you're doing it. And the point that you make is really driving this issue about surfaces, hygiene, and touching what is called the T-zone. I had to say, right at the beginning, I knew those were the things. But when I got the input from the specialist again about a week ago, I looked at myself and said, oops, I actually touch my face all the time. So thank you for pointing that out to me, sir. And I know that that's a behavior change that I have to work very hard on. In terms of the community health centers and the chronic medication, right at the beginning, sir, so there was when we started our planning. Now, I mean, Dr. Karim is on this line with me as well. One of the areas that Dr. Karim is responsible for is for the medical depot and pharmacy medicine or medicine management. So it's our contract with the CDU, the chronic dispensing unit, and also our central medical depot for getting medication. One of the first highlights in November last year at our management meeting, Dr. Karim raised a risk and a red flag for us when COVID was taking root in China. One of the biggest risks was that he pointed out to us is that 50% of the raw products of all the medication in the world that's made by pharmaceutical companies comes out of China and India. They raised an issue with us that our raw products that is required to be able to make the chronic medication, for us to be able to provide that to everyone, will be a risk. So right from the outset, we've had a team of people that's been working very hard at trying to secure our chronic medication, trying to secure generic alternatives, working extremely hard. And we have put a system in place, Honourable Maria, right from the start, that one of the first things when we asked people not to come to health facilities was say, can we get chronic medication to people in their homes? So that's why we had that system in place. We have people working very hard on that. And therefore, it is a matter of having the stock of the medication via our distribution network, which in this case is we actually worked with Uber to take it to community health workers and community health workers into people's homes. And that is the distribution network. And then making sure that we have the medication at the facility level as well. So you're very right. We have in the metro alone 4 pharmacists working only on this. And there's now a line being created for people to say if they don't have the medication, they can contact the WhatsApp line to be able to help, to contact us. And I've personally, Member Maria, when people have contacted me via email or WhatsApp, I've personally put them in touch. And I've had all these report backs that people's medication are being delivered personally to their homes by this system. So we take it very seriously and we're working very hard on it. Obviously, after COVID, we have to spend a lot of energy to make sure that we maintain this. So your last question is a very interesting one. We recognize that of the people dying of COVID, the majority actually have been told that they've got diabetes and hypertension. But there's a small minority where people have died and we suspect that they actually have got diabetes that was never detected. So there is a minority, and I think your point is very well taken. That's why we have now, and that's what we gave you, this high risk, medium risk, low risk approach to diabetes is something that we want to launch now, but we're launching it in COVID because it's a big risk for COVID, but it's something that we want to sustain. So the drive for diabetes is a very important drive. And I like what you're saying about doing it to the scale of HIV, because that is what's required. And we really have to put our energy in afterwards. If I can go to Honourable Heron. The Honourable Heron, that cost that we give there, the rental cost, is because it's an operating, it was a center that was operational. So part of what we had as an option, if we say you take all the rental away, then people can say, well, then they will take all their operating things away, then we have to bring it ourselves. That would have been a big cost to actually do. So the other places you're talking about that we've gone into didn't have that. So there is no rental agreement with Bracken Gate because they're not an operating center. It was an empty warehouse. We virtually just got the warehouse so that we can put the stuff in to be able to do that. And the Tusong Center in Kailicha is specifically it was a sports rec center from the city. So there was not it was just there as a sports center, and it was handed over to MSF to work with it. So there's not equivalent rental things because there was not an operation busy in that specific place. Just to your question about Q&I, just to explain to you, what that line in that presentation means is that our previous default is a default that's in line with the NICD guidelines and the national guidelines, which actually reads the following. Q&I is preferably a position that you should do at your own home. And if you are not by means to do it, we offer you a designated facility in a state facility. So the previous default was, we first check with the person, can you do it at home? And then they said, what do you mean, can we do it at home? Is there a separate room? Can you separate yourself? Can you put a distance? Can you close the door? Can you do this? Can you be separate from other people more than 2 meters? And those are the questions. So the default previously was, after those questions and say you can't do it, okay, now we offer you to go to designated facilities. What is different now, we start with the default is to first say, we offer you a designated facility, and it's up to the person to convince us actually they can do it at home. So I just want to understand that is the switch that you saw in the slide. In terms of barriers for medically not qualifying, I think the issue there was specifically that in terms of what we put as the criteria for isolation and for quarantine is whether there is a positive test and whether you're in that window of whether you are infective to other people. You know, so it's kind of the medical reason why you should be in a quarantine isolation facility. What has happened now is there's a lot of, and also if you're in quarantine, whether you've been in close contact with some. So a lot of the people that we find, either the contacts or the positive people, is we get the positive result back, it is day 11, it's day 12. So from a medical perspective, there is no medical advantage because I'm actually about to also, probably at the next time I see you guys, will tell you about the new proposal from National now, that the MAC has done a proposal to the National Minister, and it's about to become a guideline, that the isolation quarantine will now be cut to 10 days because the evidence is suggesting now that from 10 to 14 there's actually no benefit in terms of the infectivity. So mainly the non-medical is required to the latter is finding somebody positive after 10 days already or 11 days. So there's no medical benefit from, and now in hindsight, the new guideline is going to say 10 days is a cutoff anyway. So I hope that explains it clearly to you. Then from the ANC, the Red Dot project, just to explain, the Red Dot project was always brought online to be scaled up commensurate to demand. So with Public Works, we've actually said to them, bring on the facilities for Q&I commensurate to demand. So you'll always see in the Public Works report, which I saw that they made a big presentation to you, to the committee, is they say we could potentially get to 40,000 beds, but we only use 4,000 because there's no point if the 4,000 is only 1/3 full that you bring 20,000 online. So it's always been commensurate to demand. So the same goes with the Red Dot. We contracted in the taxis with the taxi associations through that company, and we made them available in accordance with the demand. So it was never oversupplied. What has happened, the Red Dot has been so successful that there's been a request for rolling it out more rather than contracting it. And there's 2 areas where it's been rolled out into more. So there is still a lot of people in the metro, even though 80% rejection rate, there is still people taking it up. So there's daily trips from each sub-district. People are being picked up, they're being taken to the place, and also people are being brought home. So there are routes that people do, and in a metro, it keeps them quite busy. But what has happened is the request for Q&I in rural areas has grown so much that there's an expansion of Red Dot into the rural areas to be able to do that. And then the second area, which you also know is a big success, is we started Red Dot at the beginning, what was called Red Dot Light, for healthcare workers because of the original level 3 regulations that stated people couldn't travel or be on the road after 7 o'clock at night. So we then brought that in at the same time to say, can the Red Dot taxi then at 7 o'clock pick up health workers that are working their shifts till 7 at night and take them home safely? That has been such a success that there's been a request for Red Dot to be rolled out to more healthcare workers to take them safely home at night. So that's just to put that into context in terms of Red Dot. Then the capacity and the infrastructure, you're very right. There's a lot of infrastructure challenges, and part of Honourable Dugmore's question also about the unhappiness in management at Tygerberg is linked to the example you're using of Google Earth. Tygerberg Hospital is an old hospital, and the infrastructure is really inappropriate. And anybody that knows Tygerberg knows it's a west and the east side, and you know why it was built in that way. And therefore, the infrastructure project of rebuilding Tygerberg has been one of the things that we've been working very hard, and our priority was a Tygerberg Regional Hospital so that we can move out of the old infrastructure. So similarly, we've had infrastructure projects that we've prioritized to replace Google Earth for exactly that reason. The problem is COVID has put all those projects on the back burner. And that's another side effect of COVID, is that we've not been able to proceed with our normal infrastructure priorities. Obviously, the point is what COVID then shows out the infrastructure inefficiencies that were already in those facilities. So I agree with you, Honourable Member, that we need to come back as a recovery out of COVID and say, where are the health facilities that is in greater need of replacement? And how do we speed that up with our public works colleagues in terms of a new way of actually getting into that? And Google Earth is definitely one of those places that for many years we should have replaced that facility already. It's really something that we should prioritize going forward. Then the hotspot strategy, the intention really is that it's multi-sectoral and it's in each area, member. So I'm not sure how we make that available, but there is, like you've seen in Khayelitsha, I know, for instance, in Klipfontein, there is a very active community-led intervention in Nyanga. I also know there's one in Gugulethu. So we must just maybe get the details through. And if you send me an email, I can make sure that the local details of those multi-sectoral engagements are made available to everyone. Then on the DA questions, Honourable Mackenzie, I think the airborne, the evidence that's emerging around COVID being an airborne disease has got far-reaching implications. We are looking at the technical implications, but you understand that the Ministerial Advisory Committee is the one that will guide us in terms of this. So they are looking at it, so we don't want to have a duplication of effort. We also work very closely with the Ministerial Advisory Committee. That's under Professor Salim Abdul Karim, and you would have seen Professor Mahdi from WITS also making pronouncements on that. So they are considering this airborne issue as a very serious consideration, and we're expecting some guidelines from the Ministerial Advisory Committee on how to adjust our strategy in light of that. So everybody's looking with interest what that would be. Then the question that you say, this where we are now. So let me put it to you this way. What I presented to you is that we're still working on a risk scenario that we potentially can have an increase in cases and an increase in deaths and an increase in hospitalization. What we're tracking, more and more we're tracking, is that that risk scenario is unlikely to happen. So that is what I presented to you. That risk scenario is unlikely to happen, that we're going to have an increase of deaths and an increase of hospitalizations because of the pattern we're seeing over the last couple of weeks. So what does that represent to us? I believe it represents to us an opportunity to flatten the curve and not to have a second or a third wave. But therefore, we require a very, very hard drive on behavior change, which Honourable Maria pointed out, is the one about breaking the habits and really getting into every local community to say, can we get the uptake of mask wearing, social distancing, hand washing, surface washing, and not touching your face? Can we really get that as a collective? I really believe everybody in society in the Western Cape must work extremely hard to drive that at local community level to be able to do that. So we have an opportunity to be the destiny of our own curve. That's actually the logic that I think what we're facing now. Just in terms of the field hospital staff, I think the point we made, I didn't give you that exact figure, but we were thinking at the moment there is 300 staff members vacancies associated with the field hospitals. At the moment, the field hospital, let's take Hospital of Hope Convention Center. We could have 860 beds there. At the moment, we're comfortably managing 400 beds. And there is still some staff vacancies, but potentially we don't have to fill those vacancies because the 400 beds seems to be sufficient for what we're doing now. So those are the decisions we have to take in relation to that. And the same with Bracken Gate. We're about to open Bracken Gate next week. We already have 300 staff members, but we can, with that 300 staff members, then take patients in there and create more capacity in the system. So you're asking where does the money come from? So I can tell you that there will be an adjustment estimate presented, I'm understanding, to the committees. I know that we are going to the standing committee on our adjustment estimate in 2 weeks' time. And that has been forwarded now at Cabinet. And the details is, you're right, we got very little money from National in relation to this. We got about 500 million extra for the HIV conditional grant. That doesn't touch the 2.4 billion that the health department said they needed. But you can now know from our input, we might not need the full 2.4 billion, but there's been internal provincial reprioritization and a commitment from the provincial treasury to give the health department some additional surety for additional resources so that we can actually mount the response that we need to do. But the details thereof will be in the adjustment budget estimate that's being set up as part of the parliamentary process. The PPEs is definitely enough, sir. I liken the conversation with PPE. It's not about whether PPE is enough. It was the conversation about having a conversation with people that feel anxious and feel convinced that whatever PPE is being prescribed is not sufficient to protect them. That was the conversations we've been having. So we have got sufficient PPE stock, and we are continue having those conversations. I think this whole aerosolization, airborne disease thing is going to have an impact on how we deploy PPE, but let's wait for the outcome from the MAC process. Then community screening, just to make clear, our community screening was very much done in relation to our existing NPO partners that houses community health workers. But in addition to that, we've also got additional community health workers through nationally funded HIV conditional grant NPOs. So we got additional community health workers from an additional national fund that we added to our existing NPOs with community health workers. So there is our existing NPOs, and there is additional community health workers through contact with a handful of organizations that were funded from national. And then smokers, is very interesting that you asked that question, because somebody in the Human Sciences Research Council, HSRC, has formally approached our department to answer that research question. When we've answered it, we will make it available to you. We don't routinely collect people's smoking status as routine information. So it's very difficult for us to go back and say, of everybody that died, how many were smokers, because we're not routinely collecting it. But there's a proposal in the research proposal to go back to try and answer that question. And when we have it, we will make that available to you. And then there are specific guidelines for what a Q&A center should do. Dr. Engelbrecht has been very instrumental as well in that part. So there are specific guidelines that we can, in documents in writing, send to you, because these are what a Q&A facility should do. And we have documents that describes that quite in detail. Thank you very much, Chairperson.
Thank you very much, Dr. Cloete. I just want to see Honourable Philander, is that a point of order? No, it must be an error. We have 20 minutes left of the meeting, and we do have some documents that we have to sign off as a committee. So I don't think we will have time for a third round of questions. I know that there were 1 or 2 outstanding questions, but I'd like to invite those members to submit them in writing, please. As usual, by 1 o'clock, by 12 o'clock on Monday, we'll then, Dr. Cloete, just send those questions in writing to your department. We'd then like to thank you very much for preparing the presentation. Thank you very much for sharing this information for us and for answering all our questions. To you and your team, they've done an absolutely fantastic job in very, very difficult times. We thank you very, very much, and we wish you well in the coming weeks. I think we will see you again in about a month, and hopefully you'll bring again some good news for us. So thank you very much. Take care and stay safe.
Thank you. Bye-bye.
Thank you. Bye.
Thank you.
Thank you.
All right. Okay, members, thank you very much for those very good questions that were posed to the department. Again, if you have any questions for the department, please, if you put those in writing to our procedural officers by Monday at 12. Also, if you have any resolutions, you're welcome to put those in writing, unless you'd like to table them now. I would like to propose a resolution for this committee. As you know, we have a weekly report from a number of questions that we determined several months ago. I think it was in April already, that the department has been providing to us on a weekly basis. I think given that we're in a different phase of the pandemic now, I'd like to propose that we amend that set of questions to keep some of them, remove some of them, and add some of them. So with the committee's permission, I'd like to propose that we include questions on the availability of oxygen and oxygen supplies in the province, given that we've seen that in other provinces there are oxygen constraints. So I think it's important that we understand what it looks like in the Western Cape. And then also to add hospital admissions with COVID patients, so that we can see how full hospitals are with COVID patients, and then perhaps remove the questions on the number of tests, because we already get those through the press statements, and then remove the questions on delays in testing and on the peak and on the gene expert machines. Would the committee be in favour of us doing that?
Chairperson support, Deirdre Bartman.
Agree, Chair.
Great. Thank you. I'll then put those in writing and we'll circulate that revised questionnaire to all committee members. We then have 2 documents to consider and adopt. The first is the draft committee report on our activities for the month of June. That has been emailed to the members, and I'd like us to please go through that now. All right, page 1 is membership. Page 2 is the background of the committee, which is the same as from the previous reports. The rules of engagement, which you're all very familiar with. The themes covered in June. Then under 3, we have the public participation process that we agreed to, which is now launched. The questions that we agreed to. And then the presentations from the Department of Health. Okay, and then it was the discussion on the court judgment and the legal note from the WCPP legal department. Right. And then some acknowledgements. Okay, are there any edits or amendments to the document?
None, Chairperson.
Thank you. Could I then have, thank you, members. Honourable Lecker, do you have an edit or amendment? Honourable Lecker, I see your hand is up. Okay. I'm not sure if that's deliberate or not. Honourable Lecker?
Can you hear me now?
Yes, I can hear you now.
Yeah, I actually wanted to say I hereby move for the adoption of the minutes or of the report.
Thank you very much, Honourable Lecker. Could I have a seconder, please?
Seconder, Chair.
Thank you, Honourable Philander. The report is then duly adopted and it will be ATC'd. We then have the consideration and adoption of the draft committee minutes of the 18th of June, which was the meeting where we considered the legal note. Please check that the attendance is correct. Okay. And then we move down to the substance of the meeting. Okay. Keep going. Then the discussion. And so conclude the minutes. Oh, so I beg pardon. And then the questions for the public participation. And that's it. All right. Are there any edits or amendments to the minutes?
None, Chairperson.
None. Thank you. Could I then have a proposer and a seconder for the adoption of the minutes?
Move to adopt, Chairperson, Deirdre Bartman.
Thank you, Honourable Bartman.
Wendy Philander, second.
Thank you very much, Honourable Philander. Then our next meeting is scheduled for Friday at 2 o'clock on the theme of citizen surveillance. I must just alert the committee members that we have still not received confirmation from the National Health Department. We have been in conversation with them over the last 3 weeks, and we're still hopeful that we will receive a confirmation shortly. However, if we have not received a confirmation by the end of tomorrow, I will then cancel Friday's meeting and you will all receive a notice of cancellation of meeting, in which case we will see you next week, Wednesday, where we will be on the theme of health again, and we will have the private hospitals and the hospital facility boards, as well as COVID survivors speaking to us. All right. Honourable Dagmore.
So, Chair, I just wanted to know, are you going to deal with resolutions from this meeting?
I did give an opportunity earlier. There didn't seem to be any takers, but if you do have a resolution now, you can table it now, or alternately, you can put it in writing.
Okay, but is that a guarantee that it will be adopted if I put it in writing?
It will then come to the next meeting for the committee to discuss.
Yeah, no, Chair, it was just that, there was an indication that the department was prepared to make available the statistics by ward. And I just wondered if we could request that information within a week. Is that possible that we could support such a resolution to make a request to that effect?
Yes, I believe so. If the department is able to deliver it, absolutely.
And also,
are there any objections to that resolution? Doesn't seem like it. Okay, so we will note that as a resolution of the committee. We will then write to the department.
Sorry, can I just respond to that? I think we need to, we need to be more specific in terms of a particular ward. We have over 100 wards in the metro, and if we speak provincial-wide, we have a substantial number of wards, and I'm not sure whether, that all that information is required. Thank you.
Chair, if I could just say that Dr. Kluti indicated that they do have that information available across the wards. So that is why I'm just requesting that we formalize a request for that information. He indicated that they do have that information available. And I think it's important for us in constituencies to actually have that information available to us. Thanks.
Thank you. I think if the information is available, absolutely, we can. We'll ask for it, and if they have it available, what I mean to say is that we should receive it relatively quickly. On that note, there was also a study of the comparison between the provinces that Dr. Kluti referred to, which I think if we could also request that document from the difference between the Home Affairs death data and the recorded COVID deaths, and the comparison between the difference in the differing provinces. I wonder if we could request a copy of that document as well.
Yes, Chair, I would support that. And also remember, he said he would come back to us with the infection and mortality rate per 100,000 per province, so we can just get a sense of the state of the pandemic in various provinces.
Okay. I think then we'd then request all three documents unless there are any objections. None. Okay. I'll ask Ms. Adams to put that together in a letter that we can send off to the Health Department to receive those documents sooner rather than later. All right. Honourable Lecker, I see your hand.
It was an error, Chairperson.
Okay. All right. Okay, so then with those resolutions, if there are any additional ones or any questions that we need to pose to the department in writing, please let us know by Monday, 12 o'clock. If there are no further items, then I would like to thank our procedural officers and our senior Zaida Adams and Lizette Klutter for their very hard work in putting together all the documents and ensure the smooth running of this committee. So we'd like to thank them. And if there's no further items for discussion, we will see you all either on Friday, hopefully, and if not next week, Wednesday. So thank you very much, members. Please stay safe, stay warm, and have a good rest of the afternoon. The meeting is now adjourned.
Thank you.
Thank you, Chairperson. See you Friday or next week. Bye-bye.
Bye.
Thank you.